And welcome to this short webinar looking at hip and groin pain in the active population. This webinar is specifically looking at the terminology and what is the agreed consensus among the experts. My name is Binoy Matthew and I'm an ESP in the NHS and also privately. My area of interest is overuse lower limb injuries. So, talking about groin pain. So groin pain is a common problem, but it's renowned for being a complex issue as well because it's rightly called the Bermuda Triangle of sports medicine. There's a lot of diagnosis and it's both MSK and non-MSK, so you get a lot of overlapping pain referral patterns, and the area is complex, and it's very common for multiple pathologies to coexist. Because the hip joint is so deep, it's poorly localized, and most people come with lateral hip pain and they can't really pinpoint the exact location of the symptoms. And there's a massive influence of other structures such as the lumbar spine as well as the pelvis. So definitely we need clarity on this area. And a lot of confusing terminology is used, such as athletic groin pain, groin disruption, osteitis pubis, sportsman's groin, sports hernia. So that it doesn't really help a lot of clinicians because we really don't know what they mean with each other, and they might not be necessarily linked with the pathology. So I think this lack of consensus adds confusion to this already complex area. Fortunately, this issue was addressed in the first World Conference on Groin Pain in Athletes, which was held in Doha in November 2014. A group of experts, I think around 24 experts, decided on a standard terminology along with the definition for groin pain. The way they did it was using a Delphi process and looking at a clinically based taxonomy, because the reason I like this classification is you don't need an imaging. It's based purely on subjective as well as objective measures, and this has been published in the BJSM in the article here, and I would highly recommend it, and it's an open access. Most of the points have been taken from that article. So if you look at chronic groin pain, we'll be looking into three clinical categories. One is the defined clinical entities, which is the adductor groin pain, Iliopsoas, Inguinal, and the pubic related groin pain, which I'll be going in detail. And the next big group is obviously the hip related groin pain, and the last one is the other causes, other rare causes which can still cause groin pain. So let's explore each in detail. So adductor related groin pain is definitely the most common cause of acute groin pain. And adductor injuries account for nearly 66% of acute groin injuries based on this prospective study of nearly 100 athletes. And the most common mechanism is kicking. And it tends to affect mainly the adductor longus. On examination, you might find adductor tenderness, this pain on the squeeze test, and usually there's a pain on the adductor stretch. So it's fairly localized. There is a history of recent trauma, or especially involving with rotation and pivoting, and in sports such as football and rugby. And it's more common in men. It's 3 times more likely to happen in men than in women. So that's the adductor related groin pain, and it could be a strain, it could be tendinitis, it could be tendinopathy. It's all we can say, it's the origin of pain is from the adductor region. Moving on to the next category, which is Iliopsoas related groin pain. Less common, but I see them in sprinters, also in dancers, anything which causes repeated hip flexion. And on presentation, the pain is reproduced on resisted hip flexion. And there's definitely stretch pain in the Thomas test. The important thing to note here is palpation is not reliable. So I don't think you can really get in so deep to palpate the psoas. And it's better to rely on resisted testing and on stretching than on direct palpation, because it's so deep and you have to go through multiple layers to reach that, and most of the time it's painful. Now the next group is the inguinal related pain, and it's not hernia. It increases with pain with anything which increases intra-abdominal pressure. So anything like coughing, sneezing, resisted crunches, all those things can increase the pain. Again, very rare in women, but something to be aware of, especially if they have pain in that inguinal canal region. Next is the pubic related groin pain. So this is quite straightforward. They have tenderness directly on the pubic symphysis bone, and there's no specific objective test. Pretty much it's directly on the bone, so you could say it's a bone stress injury. And many times when I scan patients who play a lot of football, you do find a lot of bone marrow edema. So it's a common finding, and it's also possible to see that in an asymptomatic football player. So it's something which I've never seen it happen purely on its own, and it can coexist with other conditions like hip pain or adductor related pathology. So generally it's termed as more like a bone overload issue. And moving on, this is the next group which I have special interest, is the hip related groin pain. So hip should always be considered as a source of groin pain because it's one of the commonest reasons, especially in chronic pain. And there's an excellent review by Michael Riemann and Christian Thorberg looking into the clinical examination of hip joint related pain. So how do you suspect that somebody has a groin pain which is coming directly from the hip? So there are a lot of key subjective which I've mentioned here. Definitely groin pain is a key symptom. If somebody complains of limping, it's 7 times more likely to come from the hip rather than from the low back. And especially clicking, catching and snapping sensation with pain strongly suggests that it could be coming from a hip joint. And it's also common to have stiffness, especially after prolonged sitting. Restricted internal rotation is also a key sign. So generally, if you're looking less than 20 degrees with some stiffness, you could be suspecting some early osteoarthritis. And the most provocative symptoms are sitting based, squatting, putting on the shoes, anything which really takes the joint into end range flexion. And also rotational, especially loaded rotation movements like getting out of the car, twisting action, all this sort of can really irritate. And certain yoga postures can really irritate if it's deep from the hip. So there's various common pathologies. Could be mild OA, it could be FIA, it could be a labral issue, it could be capsular laxity. So there are a lot of articular pathologies which can cause these symptoms. Now looking at the tests, there's not really any specific tests which we can use to rule in, but however the common tests which can rule out a very sensitive test like the impingement test, the Faber test, and somebody having loss of internal rotation points out towards a hip pathology. If somebody is pain free on the impingement test and the Faber test and they have good range of motion, you can pretty much eliminate the hip as a source of symptoms. So all these tests have good sensitivity but lack specificity. So that's again the importance of taking a good history. Now looking at the special test, unfortunately there is no special test or any specific test which can confirm the diagnosis of FIA or labral tears or even hip dysplasia. So multiple systemic reviews and meta-analysis have come to the same results, one by Tijersen and one by Riemann. I've shown that there's nothing you could do on a test wise which can really confirm the diagnosis. So it's going to be a combination of your subjective, objective, and to eliminate using the 3 tests which I mentioned before. So in summary, clinical assessment of hip and groin pain is definitely challenging, and as professionals and clinicians it's important that we agree on a common terminology so that we understand each other and there's a bit of clarity on what we're dealing with. Clinically, I find the most challenging one is to decide whether the pain is coming from the hip joint or is it extra-articular. So knowing whether it's an articular or extra-articular pathology is always difficult. And to make it even difficult, there's always usually 2 or 3 pathologies, so they normally coexist. Do you find differential diagnosis with some hip and groin presentations difficult? want a clear understanding on how best to approach FAI, CAM, or pincer hip impingements. This 2-day workshop, practical and evidence-based course, is designed for all therapists who work with physically active patients with hip and groin pain. The course will consider the evidence and how this can be integrated into practice. The active treatment section will look at manual techniques on day 1 and the rehab of articular and extra-articular pathologies on day 2. It is designed to be highly practical and full of clinical tips that you can put into practice immediately. For further information on the dates, the links are below the video. Thanks for listening, and I hope you found it useful.